Thank you very much for kind invitation. Today, I'm going to talk about the MR imaging of the inner ear after intratympanic administration of O17 water. This is my disclosures. Why intratympanic injection of O17 water? To talk about this, I have to explain what is Meniere's disease and ways to visualize endolymphatic eye drops and current clinical status, and endolymphatic eye drop can be visualized routinely with clinically feasible single-dose IV gadolinium injection. Then I will talk about how to detect low concentration O17 water. And I will show some results from the first in-human study of intratympanic injection of O17 saline. The symptoms of Meniere's disease are rotating vertigo attacks, hearing loss, ear fullness, and tinnitus. Conventional diagnostic criteria utilize the patient history and pure tone audiometry. However, recent Japanese guideline include the contrast-enhanced MRI. Pathological hallmark of endolymphatic Meniere's disease endolymphatic eye drops. And the cause of Meniere's disease is still unknown. This is healthy status of cochlea. This is endolymphatic space. And in Meniere's disease, this space enlarges. This is endolymphatic eye drops. For the visualization of endolymphatic eye drops, it is necessary to directly visualize very thin resinous membrane, but this is impossible on current clinical MRI. Or to separate end and perilymph fluid by the difference of sodium-potassium level or by the difference of protein concentration. These are also very difficult for the clinical MRI. Therefore, we have to utilize the fact that endolymph is protected from outside, either by intravenous GBCA administration or intratympanic GBCA administration. Gadolinium-based contrast agent distributes only to perilymphatic space. First, long time ago, we did a human volunteer study after single-dose IV GBCA, and we have shown that the inner ear fluid enhancement was visible in 3D FLAIR, but not T1 weighted image. In this regular contrast 3D FLAIR, the contrast is not enough to confidently separate endo and perilymph, and maximum enhancement was obtained at 4 hours after intravenous injection of GBCA. Therefore, we utilize the intratympanic injection of GBCA. Of course, this is slightly invasive and off-label use of GBCA, but we could show first-time history the dilated endolymphatic space in Meniere's disease patient as a filling defect. We waited 24 hours after intratympanic injection. After intratympanic injection, the perilymph space is enhanced, first in vestibule and then in cochlea. So we have to wait several hours to 24 hours. By using 3D FLAIR, it is impossible to separate between the dilated endolymphatic space and surrounding bone. However, by using the 3D real inversion recovery, we could separately visualize perilymph, endolymph, and surrounding bone. But there are very big demands for clinically feasible method. So we change the pulse sequence to the heavily T2-weighted 3D FLAIR, so we could succeed to visualize the endolymphatic hydrop in patient using the single-dose IV GBCA, and waiting time was 4 hours. And we modified the method, and now we can make this kind of very clear picture like 3D FLAIR, 3D real IR, using the single dose IV GBCA. Now, using the AI assisted denoising technique, we can get this kind of picture within 5-minute scan. And these are summarized in the review article on a very high impact factor journal. So let's talk about the intratympanic injection of O17 water, first in human. Of course, this is stable isotope and T2 shortening effect in proton MRI. We used a 10% molar tracer. First, we did a phantom study, and we need a very long echo time to visualize the low concentration O17 water. This is a serially diluted phantom, and this is 2-fold dilution, 4-fold dilution, 8-fold dilution, and these rows are black. So this one is 32, and this one is 512. So using this very long TE, we can visualize the 512-fold dilution. But with shorter echo time, we can just visualize 32-fold dilution. But this very long echo time, this is before injection, lateral semicircular canal is not continuous. There's some signal drop. So we have to shorten the echo time. So we decided to use a slightly shorter echo time, 3200 milliseconds. With this echo time, we can visualize the lateral semicircular canal continuously. And shorter TE image can be used as an anatomical reference. And this is a volunteer image. After intratympanic injection, 30 minutes after, signal of vestibule and the vessel time of cochlea drops. And this is another volunteer. We can see after 30 minutes of injection, you can see the signal of vestibule and cochlea drops and gradually recovers. So the O17 water distribute faster than gadolinium. And also O17 water enters endolymphatic space, not only perilymphatic space. This is another volunteer. In this volunteer, the permeation of O17 water is not so good, so the signal drop is very slight. After 2 hours, the signal almost recovers. And this is a signal intensity ratio time course. This is basal time of cochlea. For the cochlea and vestibule, in all volunteers, all 5 volunteers, the signal drops in the first session and then gradually recovers. But in the apical and middle term of cochlea, the signal drop is very mild. And very interestingly, we can see the signal drop in the ampulla of posterior semicircular canal. This is endolymphatic space. So we can visualize the permeation of O17 water into endolymphatic space. This is a patient with endolymphatic hydrops. And this is a 6-minute scan, and we took serially. And you can see just after the injection, signal drops in the vestibule, basal term of cochlea, and posterior ampulla. And this is a shorter echo image. This is an anatomical reference. And interestingly, in all subjects, we observed the nystagmus, positional nystagmus, and they complained of vertigo. The duration of positional vertigo for each volunteers are like this, from 60 minutes to 6 hours. This seems to corresponding to the degree of the O17 water permeation. And vertigo and nystagmus lessened when the head position was returned to the rest with the injected side up. After the vertigo symptoms disappeared, there are no complaints of auditory vestibular symptoms, and all volunteers returned to their pre-treatment state. In conclusion, visualization of endolymphatic hydrop is clinically feasible by intravenous injection of single-dose gadolinium-based contrast agent using modern robust method. Intratympanic injection of O17 saline distribute in both endolymph and perilymphatic space. So we cannot use this agent for the visualization of endolymphatic hydrop. But intratympanic injection of O17 saline is the first agent to evaluate the water dynamics of endolymphatic space. This is, I think, very important. Intratympanic injection of O17 saline caused positional vertigo and nystagmus in all subjects. This is probably due to the right cupula phenomenon, buoyancy theory. The O17 water is heavier than the regular water, so if the cupula in the ampulla experience the O17 water permeation, the cupula becomes relatively lighter than usual. So it might be affected by the buoyancy. Thank you for your kind attention.